Yes, we can start, Raju, now. So, good morning, friends. Welcome back to Saturday Club of Baroda meeting. And today we have Dr. Rajiv Bhatt, oncosurgeon, with us. He has been our guest speakers on previous few occasions also. Last time he talked about robotic surgery in cancer. He is director and head surgical oncology services at SCG Center, Cancer Center at Vadodara. He was trained at Tata Memorial Hospital, Mumbai, and he is also an alum of Baroda Medical College. He had his fellowships at MSKCC, New York, and Nottingham, UK. He worked in South Africa for about 3 years from 2009 to 11, and he has numerous national and international publications to his credit, and he has given lectures and orations at various forums. He actually pioneered specialized breast cancer surgery in Vadodara and many more things to his credit. I'll not take much time to introduce him more. Today, he is going to talk about cancer screening, genetic testing, and cancer detection tests. And in our group of Saturday Club of Baroda, there were suggestions that we should talk more about these tests. So Rajiv very gracefully offered to talk about it. Thank you, Rajiv. Now you can start your talk. You have about 40-45 minutes, and we'll keep some time for discussion also. Thank you.
Thank you very much, Satish. Good morning to everyone. And yes, I grateful to you for giving me this opportunity because this is a topic that I'm particularly interested in. Clearly, the way I see it now, after being almost about 3 decades in oncology, is that our focus moving forward should be on prevention. And in my mind, there's absolutely no doubt about that. We have made tremendous advances in cancer diagnostics and treatment and all of that. But we continue to be disheartened by the outcomes which are never uniform and certainly not predictable. Now, most of you already know the cancers that are common in India. Of course, we know that breast, head and neck, cervix, lung, colorectum will form the top 5, and there will be others which make up the remaining. But in keeping with the global changes, breast cancer is clearly the commonest cancer, and the incidence is rising, as we all know. Now, I just wanted to focus on this graph for a minute. It's not very difficult to understand. This is Generation X, people who were born between 65 and 80. And this is the subsequent generation that we call millennials or Generation Y. And it's very interesting to see that the Generation X's are projected to see higher cancer rates than boomers. So I am at the cusp of this boomers and Generation X, actually, just a little bit before that. But you can see that we will outstrip previous generations in our incidence of cancer that we will see in our lifetime. And this is something which is very important. Also discerning, rather distressing, is the fact that we are seeing more and more early onset cancers. The point I'm trying to make is that cancer incidence overall in a population is not going down. It will not go down and will remain high for considerable time. And therefore, our focus has to be on trying to do prevention, which in subsequent generations will reap the benefits. It may not be immediately reapable in this generation, but certainly will in future generations to come. Now, you know that almost about 15.3 lakh new cases every year. We have a overall mortality of about 50%. This is the lifetime risk of developing cancer in India, 1 in 10 in males and 1 in 8 in females. But again, what is distressing is this particular graph. And I put it up here just to show you that just over a span of 4 years, 5 years, see the steep graph of how much the cancer incidence is rising, right? And unfortunately, in our country, because of the reduced penetration of good quality cancer care, the mortality continues to remain at about 50%, you know. So this is something that we should need to keep in mind going forwards. Now, I'm going to address these 3 things, and they seem a bit disparate, but I think they're completely interlinked because the focus by and large is on prevention. And I think out of all of these, screening is the most important because there's a lot of confusion in people's mind, you know, about what screening is, Should we be screening for cancers at my age or in my gender or in my locality? What kind of genetic testing is available to me if I wish to do this? And are there any cancer detection tests? Because, just following the newspapers and the advertisements, and we see a new claim almost every other day. So I will be addressing each of these in turn, but my main focus will clearly be on screening, and then I will come to the other two as a corollary of what I'm discussing in screening. So please understand that screening is an examination that is performed on an asymptomatic individual, and it has one and only one aim, and that is to reduce the disease-specific mortality, prevent death. And for this to happen, whichever disease we are talking about has to have an effective treatment, there has to be a high prevalence, and there has to be serious consequences. So we know that for cancer, this is very much true, but we also know that there are about 250 different types of cancers. So whichever cancer we are planning to screen must fulfill these three requirements. There are essentially two types of screening. One is the opportunistic, the other is population-based. Opportunistic is when somebody comes into your clinic and requests, or you ask them to be screened for a specific cancer, whereas population-based is something that happens in a lot of, say, Scandinavian countries or Canada or the US, where they have a proper program. So it's a programmatic. Now, programmatic screening is usually more effective, no doubt about that, but it does involve follow-up and recall of patients for regular screening, and it requires rigorous quality control, right? So we have to keep this in mind whenever we are talking about screening as far as our country is concerned. What tests should we use? So for any cancer, whichever screening test we use, it should be able to find the cancer before it is clinically evident. It must improve survival due to early detection. And remember, we said that the aim is mortality reduction, not simply to improve survival. There should be a low false negative, low false positive. So that refers clearly to the sensitivity and the specificity, which you all know. And it should be having a reasonable cost, and it should be widely available even to the last person in the remotest village. That is what will qualify as an ideal screening test. Now, I'm going to just go through some of the principles which you must keep in mind. I will not make it technical, but just follow my line of thought. Come to A. This is when the disease is diagnosed due to symptoms, and this is death due to cancer. When we do screening, we will diagnose it before symptoms in an asymptomatic individual. Death will remain at the same point, and this period of advance intimation that we have that the cancer is there is what we call a lead time. Now, lead time is good provided that it can prolong life due to the screening, right? If the point of death remains exactly as it was, then all it does is that it increases our bias. It gives us an illusion of increased survival without actually prolonging life due to postponing or pushing death beyond what it would normally have been. So this is what we call lead time bias. This is a very important thing in screening that you must keep in mind. The other thing is length bias, which is essentially a function of the biologic behavior of a cancer, right? So for example, you have this tumor over here, which is rapidly growing, very aggressive tumor. And then on the other hand, you have this other extreme of a tumor that is extremely indolent and is unlikely to, grow much. And in between, you have these two different types of cancers, right? So does it make sense to screen this kind of a cancer, which is aggressive, but which gives you such little time before it will cause demise of the patient? Does it make sense to screen this kind of a tumor, which anyway is going to be indolent over possibly the entire lifespan of the person? So keeping these two things in mind, one must understand that these are the two types of tumors wherein we can do screening and we will be able to reap reasonable rewards. One of the problems of overdiagnosis is, one of the problems of screening is overdiagnosis, right? Because this is an extreme form of length bias. And actually it represents pure harm. Why? Because there is an inherent indolence of the cancer and there are competing causes of death. So not only must you reduce the mortality from that specific cancer, but you must reduce the mortality in the lifespan of the specific patient, because he might have been destined, or he might have, there would be other competing causes of death like cardiovascular disease or vehicular accident or whatever you have. So essentially what this says is that there should be detection of histologically defined cancer, not destined to metastasize or harm the patient in the lifespan of the specific patient. In this situation, if you keep diagnosing cancer, then it is clearly extremely harmful. And a classical example, which many of you in the pediatrics field will understand, is the neuroblastoma screening program that used to be prevalent in Germany, Japan, and Canada. And ultimately, when they looked at the results, they found that in the screened population, the number of diagnosed neuroblastomas were very high compared to the non-screened population. However, the mortality remained essentially the same. And some of these, as you know, will regress spontaneously. So what sense is it to screen for this particular cancer? And the program was completely dismantled. The other thing is stage shift. So you are diagnosing cancer at an earlier stage than would have occurred in the absence of screening, and this must confer a benefit in mortality reduction. This is a necessary proof of efficacy, but it's not sufficient. It's not the only thing, as I already mentioned. Then a lot of the trials will have selection bias, because you are taking healthy volunteers in which to do the screening. So you will have a healthy volunteer effect. In the general population, you'll have many, many people with multiple comorbidities. But essentially, the population that you're going to screen is going to be over a large number of years. So there will be some bias over there in terms of the selection. Please understand the difference between increasing survival and decreasing mortality. For example, say prostate cancer, right? Where screening was rampant, towards the end of the last millennia, last century, and then going into this century, doing PSAs for everyone here and there. And clearly, there was a 97% increase in the survival rate due to the PSA screening. The mortality reduction was only 23%, right? Whereas you have a disease like Hodgkin's, for example, where there was no screening, you clearly have an increase of 59% in the incidence, but the mortality has remained static at about 66% because this is a population that is non-screened. So it's not necessary that an increase in the survival rate will reflect in the mortality statistics, right? So that is something which one must keep in mind, because ultimately the aim of screening is reduction of mortality. Now, let's look at a few common cancers wherein screening would appear justified in our country. The first is, of course, breast, since it is our commonest cancer. And let's see how these principles apply to breast cancer screening. We all know that there is decreased breast cancer mortality now, world over and even in India. And the main reasons for this is that because we have a better awareness amongst the population, better understanding amongst us of the biology of the tumor, and we clearly have more effective treatments, be it new drugs, new strategies, new sequencing, all of that. There was a lot of push till the 2020 decade that screening programs and early detection also contributed to a reduction in cancer mortality. And we now know that this isn't really true. Why is it not true? Have a look at this graph, okay? Over here, we are clearly seeing the age-adjusted incidence in green of invasive and non-invasive breast cancer. This is the incidence of invasive breast cancer. This over here, solid line, is the mortality reduction, right? And you have baseline mortality, which has gone down from blue to red over the decade, purple over the decades. And you have baseline incidence, which has grown from this blue to this orange over the decades. In other words, what has happened is that the incidence of breast cancer has increased from approximately 105 to 111, depending on whether it's invasive or non-invasive, to 165 per lakh population. And this is US, which means that there is an excess of 54 breast cancers per lakh population. The mortality reduction has gone from 31 down to 22 in the same period, which is a reduction of 9 deaths per lakh population. So what this is doing is that the mortality reduction does not reflect the increasing incidence, meaning that you're increasing your detection of early cancers without making any significant difference to the incidence of advanced cancers or mortality. And why is that? It's very simple, because you're seeing more and more DCIS, right? Invasive, in situ cancers. 90% of DCIS is detected by mammography. Where screening mammography is a program in Western countries, this is a big problem. Used to be 1 to 2% before the advent of mammography, and it's now 12%. And overall, you'll find 25 to 30% of all breast cancers are detected by mammography, in the US. So essentially what it means, the take-home message here is that 1 out of every 4 to 5 cases of DCIS detected by mammography would progress to a clinically manifest breast cancer. The others may not. Very clearly seen from these statistics, and please keep that in mind. Now we have 3 tools for breast cancer screening: self-examination, clinical breast examination, and mammography, screening mammography, as you know. Benefits of screening mammography. Now we've got like 3 decades of follow-up on the randomized clinical trials, and overall they show that there is a 20% reduction in mortality because of this screening mammography. This is what was purported, this is what was told to us, and this is what we practice, that screening mammography is beneficial, one must do it every year, and the statistics are all there for you to see on randomized clinical trials. Same thing with the subsequent studies, more modern studies, again about a 20% reduction in mortality because of screening mammography. What does this 20% reduction in mortality mean, right? Let's look at the Swedish trials, where almost 4 of the trials were done there. It showed a 29% reduction in mortality. After 10 years of screening, this would correspond to 1 woman per 1,000 averting death because of the screening, right? So on the one hand, non-screened population will have 2 deaths per 1,000. In the screened population, the other way, the non-screened will have 3 per 1,000 women. In the screen, it will have 2 per 1,000 women. So the absolute reduction in mortality, 1 out of 1,000 is actually only 0.1%. Relative reduction versus absolute reduction, right? Look at that. 0.1%, and you're saying that there'll be a 20% reduction in mortality. It's true. Here is 29%, but the absolute reduction is only 0.1%, because anyway, not many people are dying of breast cancer nowadays. Similarly, the Cochrane and the Preventive Task Force reviews, absolute reduction in mortality 0.05%. Rethink the screening mammography strategy as a screening tool. What about the overdiagnosis, right? All of the trials have shown that there is an 11 to 19% incidence of overdiagnosis. And therefore, there will be overtreatment, right? Cochrane review, breast was removed in 20% more women in the screen than in the control group, which was confirmed from the Scandinavian studies. In mastectomy, in UK, the mastectomy rate is almost 30% in the screen group. What a heavy price to pay for a disease that might not anyway really kill you. What about the false positives, right? It leads to recall. How many of them? About 11% of all screening mammographies in the US, right? And this is the cumulative risk if you keep screening over 10 years. And out of the recalls, 1 in 5 will have the cancer, 4 in 5 will not have the cancer. But 70% of those who are recalled will undergo further imaging, and 30% will undergo biopsies. What a huge waste of resources and tremendous anxiety it would cause to the person who is being screened. What about the radiation exposure? Well, it's not very significant, but clearly there is a ratio. Breast cancer deaths prevented by mammography, screening mammography 2 yearly is 97 versus 1 induced by the radiation, 242 prevented versus 1 induced by the radiation. Now, this is where, we are looking at it pragmatically in India, that we are saying that instead of the yearly practice that they advocate overseas, we should be looking at 2 yearly. Maybe we should be looking at a little bit of the cusp of this age group to reduce the number of people who would have cancers induced by radiation. And of course, we all know the other hazards of this screening mammography. As I mentioned, you are increasing your diagnosis of early stage cancers without making any difference in your diagnosis of late stage cancers. Big mistakes. There's an excess case detection of 114 per lakh, but you're not able to reduce the advanced cancer that you're seeing, which means that the mortality reduction is really not happening because of screening. And of course, there are, the confounding factors, as I said, that you have to look at survival versus mortality. What exactly are you seeing? It's not necessary that if you detect a case, everybody, seems very, was detected in health checkup. This was a health checkup included mammography and clinical examination. You need to answer whether it was by clinical examination that it was incidentally detected in the health checkup or by screening mammography. And even if it was detected, it might be at an advanced stage. You might not have the natural history modified, or it might be so indolent that it might never be threatening in the patient's lifetime. So also the screening strategy needs to be revised. It needs to be rethought as far as India is concerned. And, I mean, people have done that in this country. And what we currently follow are awareness-based early detection, right? We increase people's awareness, provides disease-specific information to all the general population. Tell them about the importance of these two things, the self-examination, the clinical breast examination. And more important, you promote a self-realization of the importance of prioritizing their own health. Women generally tend to neglect it. We all know that. And look at these statistics from our country, right? The awareness, 16 to 41%, less than 10% of women in our country practice breast self-examination. And please remember, breast self-examination is not a screening tool that it decreases mortality, but it makes the woman more aware of the normal feel of her breast, so that when something abnormal happens, she will pick it up earlier, right? And clearly, this is what was echoed in a number of studies that have come out in our own country. And this is the largest trial that we've had and the longest follow-up. In India, it was conducted essentially in Mumbai. And the original PI for this trial was Dr. Indranil Mitra, who unfortunately is no more with us, my teacher also at Tata Memorial. And what they said was that this is the recommendation that we should be giving. Divide women into average risk women and high risk women, and then advise mammography accordingly, because then all the hazards would appear justified in this group, and this group doesn't get exposed to all the hazards unnecessarily, right? And of course, these are the statistics. It's an excellent paper. I would urge you to read that whenever you find the interest and the time. So these are the tools. So this is what we currently advocate. At all ages, you should do breast self-examination. From age 35, clinical breast examination by a doctor annually, at least. This now is being looked at, and we're looking at 6 monthly rather than annually. And between 45 and 65, do biannual screening mammography. Cervix. We know the risk factors, and we know that HPV is one of the biggest risk factors, and there are others, but clearly HPV is the predominant, right? Again, the aim of screening here is to detect high-grade lesions in asymptomatic women, treat them, and prevent the progression to invasive disease. And if you have to detect invasive disease, do it in an early stage so that the cure rates are very high. You know that the cure rates in early stage cervical cancer approach almost 80% for stage 1 and 2 put together. And this is how we really look at it, because the HPV infection occurs at a much earlier age. This is pre-cancer, the purple, and green is the cancer. It gives us a huge, huge window over here for primary prevention, and we are now doing that with HPV vaccination. Secondary prevention, where we do a screen and treat, single visit approach, and you do point of care rapid HPV testing. And actually we do co-testing if possible, that you do the pap smear and the cytology as well. And you follow with immediate treatment, which should be available at that site. You can't tell the patient that, look, I found a pre-malignant lesion, but you will need to go XYZ 50 kilometers away for the treatment. And of course, tertiary prevention, we are all very well aware about, and people tout that this is where we made our advances. I would rather counter that by saying that this is where we've made our advances. We now have vaccines, right? These are the 3 tools that we use for secondary prevention: pap test, VIA, visual inspection with acetic acid, and HPV testing kits. Right? And this is what it looks like. And remember that this is actually a very dynamic, journey. I mean, infection with HPV, it can progress, it can regress to a precancerous lesion. But once a precancerous lesion has been there for quite some time, it will progress to cancer. The key here is HPV viral persistence, and that is what causes cervical cancer. How does this happen? Like, these systematic review brought out in 2003 showed that if women have CIN2, that is intraepithelial in situ cancer, right? 2. Then approximately 43%, 57% will regress. 57% will regress, 43% will remain about the same, and 32% will progress to CIN3 over a span of 12 to 24 months, right? These were old statistics. Now look at the new statistics. 2018, this very interesting paper, combined 36 studies. Regression happens in 50 to 60% of cases, right? 30% will stay as CIN2. And progression will occur only in 18% and 11%, depending on the age of the patient. And overall, that would mean that 1A1 stage, 0.4% will develop it. More than 1A1 stage, 0.065. So progression to stage 1, wherein even otherwise the cure rate is upwards of 90%, is quite limited. Which begs the question is that, should you really be treating all CIN2 lesions? So active surveillance is probably a better strategy, and this can be easily practiced anywhere in the periphery as well. These three, as I said, this is the protocol that we follow. It's available on the net. In fact, WHO has set targets for us. These are the two vaccines. We have our indigenous vaccine and the quadrivalent Gardasil that's available. We advise vaccination for all girls between the age of 9 to 14. And clearly, the thing that we need in India is not actually extensive screening protocols, which are costly and difficult to maintain quality in, but increased penetration for vaccination. And this is something which I'm very happy that our Prime Minister has put as a priority. And this is where we are headed, that the vaccine should be available for everybody, even from the PHCs in rural areas. Prostate. Now, prostate, you know that most of the cancers occur in the peripheral zone, and when the volume is more than 0.2 ml, it is when it is detected either by symptoms or by signs. 18% will be detected only by a simple digital rectal examination, irrespective of what your PSA will show. The role of PSA. Well, look, honestly, there's no optimal PSA threshold for detecting non-palpable but clinically significant prostate cancers, right? This just shows you the PSA level with the risk of prostate cancer increasing as the value increases. But one needs to put this in perspective, and there are many nomograms that will help in predicting and then guiding treatment. PSA screenings we know are controversial. We've already alluded to that, so I won't waste time. But just look at what happened when PSA screening was used indiscriminately in the 3 decades over here, right? It jumped the incidence of prostate cancer. Now, no biology of a prostate cancer can describe this sudden increase in the incidence over just 10 years, right? It increased purely because your screening strategy uncovered more cancers, and then we got wiser over here, and now we are falling back to actually where it was, because we don't use PSA indiscriminately in this screening for prostate cancer, right? This shows the stages, right? From PSA promotion to discouragement. So what are the current guidelines? Well, again, the same thing, that you've got to do a risk-based approach to the screening, and you don't, inform about screening unless they are ready and willing to accept the follow-up and the regular processes that are combined with it, right? And these guidelines are easily available. This is what we are generally following. And then it stratifies the patients. It gives you very clear-cut age cutoffs, the PSA values, stratified based on family history, PSA density, velocity. There's a risk calculator. And then finally, it goes all the way down to the treatment, what kind of a treatment, so that this will prevent any unnecessary over-treatment and over-diagnosis. Of course, the MRI is now an essential tool, and like BI-RADS for breast, we have PI-RADS for the prostate, and this is hugely successful in wherever it has been implemented as part of the risk-based screening approach. Once again, the relative versus absolute risk, right? This study published in 2009 showed that the reduction of prostate cancer deaths by 20% meant only 1 prostate cancer death averted per 1,000. So the lifetime reduction was 0.6% only. Clearly question whether we need to do extensive population-based screening protocols for this. Lung. Similarly, sputum cytology, chest radiography, we clearly know doesn't really benefit in terms of screening. It will lead to 18% unnecessary overdiagnosis, especially in a country where tuberculosis is still pretty prevalent. But this was one of the largest lung screening trials. And what it showed was that there is a reduction in mortality of about 7% when you do a low-dose CT scan in a particular patient who is at high risk, right? So again, risk-based screening, in a defined population, you will achieve your reduction in mortality without affecting and going through all the hazards. What does a low dose CT mean? It means that in a patient with BMI less than 30, you're getting less than 0.3 milli SVs of radiation. We all know the hazards of screening. It's the same thing over here with low dose CT screening. So we've got to use it judiciously. The way that we calculate pack years is very simple. And based on that, we divide patients into high risk and low risk. And this is the approach that we are following at our center, and many other centers in India also would be following this, that if the patient is a high risk, then subject them to low dose CT based lung cancer screening, otherwise not. Colorectum, same thing. The risk factors now are very well defined. We know that. This was the EPIC study, which actually showed that just adhering to 5 healthy lifestyle factors versus those who adhere to less than 1 risk factor, hazard ratio points. So there were 40% more colorectal cancers developed in those who did not adhere to or who adhere to 1 or less of these 5 lifestyle factors. And we know all of this. So this is again the risk-based screening protocol for colorectal cancers. This is how we follow it. And essentially it's a shared decision making with the patient, because it's going to happen over a number of years. The patient has to be reliable for that screening, follow-up and counseling. Oral cancer, one of our biggest problems, but a site that is very easy to examine, right? And this was a cluster trial that was carried out in our country, and it clearly showed that there is a reduction in mortality as well as a reduction in the incidence by the use of regular examination and intervention, right? It's beneficial in, again, high-risk individuals. So you've got to define high-risk individuals, and then you have to follow a proper protocol of examining so that you don't miss these early cancers, which patients often tend to miss. Difficult sites to locate, and then they progress to this kind of thing, So overall, if I have to conclude the screening part of my talk, we are now following risk-adapted screening strategies for many, many cancers, right? We have about 8 or 9 cancers in our country where we feel that it is justified. And why we should do this? Because it should, you see, it's unnecessary to create fear, right? We have to ask the patient when they first come to us and ask for screening, or somebody talks to us about screening, that what is your family and personal history? Are you at a higher risk than the normal person? Are you fearful because you have read so much and been bombarded with so much information that you just fear the cancer and therefore want it to be screened at any cost? I want a PET scan every year. I want this, I want all that anxiety. So why of the screening has to be very clearly discussed with the person who comes to you. I won't say patient, because this person is actually a healthy person. And then you have to do a risk stratification based on all of this. There are models and you have to do certain tests and all of that. So you do a risk stratification and then give your decision for that particular person. It's a shared decision. And this is what we will call a risk adapted screening strategy. And this is what is going to work the best. And this is what we are going to have to do everywhere in order to reduce our incidence in the coming generations, and therefore to reduce our mortality as well. So recapping, these are the cancers where you have the risk adapted screening method with these tools. And as I said, this is what we follow. This is what we would advise. Now, coming to the next talk about part of my talk about genetic testing. Right, genetic testing, you must remember, is different. There are 2 types here. We are talking of genetic testing and we're talking of genomic testing, right? Keep that distinction in mind. Let us first look at genetic testing. It is the identification of inherited mutations, right? Which means we are doing essentially germline testing. Were you born with these mutations, right? And it is predictive for hereditary cancers, right? So we will know that if the patient has this particular, or the person has this particular gene, he's likely to develop cancer at this particular time or roughly in this period of his life. And therefore, we will now take appropriate measures to see that he doesn't develop the cancer, or if he develops it, we can detect it in an early stage where the cure rates again will be upwards of 80 to 90%. And this is generally done in the blood or the saliva. Please remember that inherited cancers form only 5 to 10% of all cancers. right? You'll have about 25% that are formed by that are called familial cancers, which is because of a shared environment or happens in a cluster. I have a very interesting list of about 22 couples who have developed cancer, unrelated cancers. The wife is being treated for one cancer, the husband develops the cancer, right? There's no inheritance here or no hereditary mutations. It's just a shared lifestyle which predisposes, shared environment which predisposes to this. And when is genetic testing done? It is done in people who have a family history of certain cancers, people who already have a known history of one cancer but are likely to be predisposed to other cancers. For example, the Lynch syndrome, right, where you have deficiencies in the mismatched repair genes, the MMR. So if somebody has that, we know that even though we are now treating that person for one cancer, his likelihood of getting maybe 12, 14 other cancers is very high. And also in family members of persons with known inherited gene mutation. So this is where we will do this form of genetic testing, which will be confined essentially to identifying inherited mutations. And what does this do for us? It informs the cancer screening strategy for that particular person based on the individual risk. It allows for a good surveillance strategy and therefore better compliance. And where appropriate, we will give risk-reducing options and treat if it is applicable in any of the cancers where we can. For example, prophylactic mastectomy, which is essentially a risk-reducing option for patients who have BRCA1, BRCA2 positive cancer. Genomic testing, on the other hand, is identification of the individual's genetic mutations or protein alteration. This is done at the individual level, and these mutations happen during our lifetime. And it's not just one, stimuli that is causing this mutation. We know that it requires hundreds and thousands and millions of hits to the cells before they start mutating and turn into cancer cells. This is also known as somatic testing, genomic profiling, biomarker test, tumor DNA sequencing, molecular testing or profiling, tumor subtype. All of these are essentially forms of genomic testing as opposed to genetic testing. And this can be predictive and prognostic, but for that individual cancer and in that specific person. So I hope I make this distinction very clear. And what this genomic testing does is that it informs the prognosis. It can allow us to switch treatments or select the appropriate treatment, is what we call targeted therapeutics. And it may also tell us that there is a need to do germline testing because we are seeing this particular gene alteration. But remember that genomic testing is not enough to classify a person as having an inherited mutation. You've got to go back to the classical testing for the inherited mutation, right? So whereas it will give an indication, it is not sufficient to label a person as having a hereditary predisposition. So distinction between genetic testing and genomic testing. And this is usually done on tumor tissue, but it can also be done on blood, saliva, and body fluids. But primarily it is done on tumor tissue, either from the biopsy or from the final specimen. And how does the risk vary? Okay, you have on the one hand common variants of the cancer. They have certain genes there, but the penetrance is low as far as subsequent, say, generations or offspring are concerned. Whereas on the other hand, you have the rare variants which have a high penetrance, like the BRCA1, BRCA2, and this is likely to be a dominant phenotype in the kindred. Now, whenever you will do a genetic test, you will see that the report comes back like 5, 6, 7 pages, and anyone who has attempted to interpret that report is completely disheartened. And I can tell you that this is also true for doctors, right? It is also true for a lot of oncologists. And the classification that is used by all testing labs is the variant pathogenic? Is it likely pathogenic? So we call this P/LP. Is it a variant of uncertain significance? Is it likely benign? Or is it totally benign, right? And then, of course, the description is there. But the most important thing here is variant of uncertain significance. Believe me, a lot of your patients or normal people whom you do this testing will have what is classified as a VUS. And I'll come back to that a little later. right? Now, what is multi-gene panel testing, right? Multi-gene panel testing actually analyzes a set of genes simultaneously that are associated with a specific family cancer phenotype or multiple phenotypes, right? So you may do a germline testing, which is relatively non-specific. You're looking for a needle in a haystack, or you can do phenotype directed testing based on the family history and the tumor-based criteria through a tailored MGPT, that is a multi-gene panel test. And this is more efficient, it is cost effective rather than doing large multi-gene panels where we really don't know the clinical relevance. I dare say that there is more ignorance about all of these tests and their implications right now than there is knowledge. And this is true for the best of centers and the best of kits that are available. Right now, as more genes are tested, there is an increased likelihood of finding variants of uncertain origin and chip also what we call we have very nice names, so essentially it's clonal hematopoiesis but of indeterminate potential. It's a good way of saying that I really don't know what this means. And try telling that to a patient who carries this report with them and goes to 5 centers trying to understand what the interpretation of that chip is or what the interpretation of VUS is, and then gets fed up and says that, look, I'm putting this away, just tell me what to do. Um, Polygenic risk scores are also available, but they should not be used for clinical management as of now. Only within the purview of a clinical trial should we be using polygenic risk scores, because essentially this is modeled and it's AI driven, right? But it's not for clinical management as of 2025. VUS, right? So alterations in the genetic code for which the impact on protein function is uncertain. Again, a good way of saying I don't know. And if this is reclassified at another point in time or with another lab, then 80 or 90% are likely to be reclassified as likely benign or benign. Only 10 to 20% will be reclassified as pathogenic or likely pathogenic. So should we be repeatedly reclassifying VUS? Simple answer is no. Just look at those statistics. Be rational, be practical. No. Also, tumor marker tests, right? All of these tests which are there in common use, there's a huge array of these tests. But these are the ones where we use based on the kind of patient, the tumor, the family history. You all know these. Alpha fetoprotein for liver and for germ cell tumors, the PSA for prostate, calcitonin for medullary cancer of the thyroid, thyroglobulin for following differentiated thyroid cancers, CA125, ovarian cancer, 1994, hepatobiliary pancreatic cancers, CEA, chromogranin A, carcinoids, 5-HIAA, and all of these, gastrin, beta HCG, and the urinary VMN HVA for the catecholamines. And of course, these are all the genes that we would be looking at: ALK gene for lung cancer, say, the BRCA gene for breast cancer, the MMR for the Lynch syndrome, colorectal cancer, KRAS and BRAF, all of these for lymphomas and leukemias, the c-KIT for gastrointestinal stromal tumors, EGFR, PDL1, so that we can have an appropriate anti-PDL1 therapy, the red gene mutations for thyroid and other cancers. And of course, you have all of these now that are multiple genes being tested. These are the commercial one, Foundation One and Foundation One, which is available in liquid form. This is for tumor tissue. Guardant, right? All these are worldwide and available, and they are have been well researched and are now into commercial use. The Oncotype DX and Mammaprint that we use for breast cancer to see whether really that patient will benefit from chemotherapy or not in the early stages, and the somatostatin receptor as well. And this just goes to show you how we are using molecular testing in breast cancer, right? We do the tumor RNA expressions, we do certain ERPR, we may also do PDL1 testing and all of that. What about this big thing that is going around everywhere, circulating DNA, liquid biopsy? Liquid biopsy kar lete hai. Let's do a liquid biopsy. Well, look, it's useful, okay, but it has a place. And outside of a clinical trial setting, it should not be used to replace well-established methods of cancer screening. So in cancer screening, people say that, look, now there is a blood test. Let's just check whether I have a cancer or not. Please check for me, doctor. And the marketing is ensuring that all of these labs have plenty of work who are doing this liquid biopsy. And people think that they can just get screened by testing whether they have blood circulating tumor cells, which essentially is measuring the DNA. And why should this not be advised? Why, in fact, should we be vociferous in going against this trend? But simply because of sensitivity, the FPR, the positive predictive value for early stage disease is not fully defined. And we don't really know the psychological impact of this testing, right? You tell a person that, yeah, you've got circulating DNA. Looks like you got a cancer somewhere. What now? Well, I really don't know. Maybe you should do a PET scan. PET CT scan shows normal. What now? I really don't know. Now, try living with that knowledge. So coming back, circulating DNA is not and should not be used as a screening tool for cancer, any cancer. Finally, I think one of the areas of interest that somebody had written was the multi-cancer early detection tests that are also now becoming available, and many of our companies are promoting. Reliance Life Sciences for one. I'll just come to that a little later. But what this does is that you have a cancer onset, and there will be certain shedding of the DNA at the onset, and there's a huge shedding window, right? This is when you will have a clinical evidence of disease. This is the detection point, and this is actually clinical detection. So you have a huge preclinical detectability window. We've already seen that this happens for a lot of cancers, right? And during that particular time, through taking a blood and then you sequence the DNA and then apply machine learning to that result, right? Machine learning is essentially nothing but results of a sample that have been modeled into that based on the compilation of maybe thousands of patients' tissue. And you either detect the cancer signal or you do not detect the cancer signal. If you detect the cancer signal, it will give you a prediction of where is the origin, but will not give you that for certainty. So you're still going to have to work up this patient to understand where it came from. Okay. These are the possible outcomes. Now, suppose you decide that you've read it in the newspaper and you want to do this multi-cancer detection test, right? Very easily available. And if you use it as a screening test, you can have two possible results. You can have a positive signal or a negative signal. If you have a negative signal, it's either a true negative or a missed cancer, right? Because of a false negative. So both of these will give a false reassurance. And that has consequences, right? It may delay treatment where it is necessary, and the patient follow-up remains unclear. Positive, you do a diagnostic workup. Diagnostic workup says that, there's nothing that I can find. You come back to this same algorithm and you keep going around this loop for a few years, before you get absolutely fed up psychologically, patient as well as the doctor, and you say that let's just give up right now. We don't know what we need to do. Or you have a diagnostic workup that will go with the risk profiled by the test, and you will make them undergo multiple imaging tests, multiple procedures, biopsies. And after all of that, if no cancer is found, it's a false alarm, anxiety over a period of 2-3 weeks, and a big hole in your pocket, right? Or you can actually have a pathological diagnosis of cancer, true positive MCD, right? For which now, anyway, there is effective cancer treatment. So had I waited maybe for the lump to become 1 centimeter when a doctor would have detected it, I would still have reduced mortality. I would have increased my life expectancy, reduced mortality, because the cure rate is in stage 1 breast cancer is about 97%. So really, what is it that we are trying to do with these tests as a screening tool? Nothing. It's just a financial burden to the patient. It exacerbates the health disparity because those who afford it do it and those who cannot do not do it. And it increases the procedural burden on the healthcare system. And this is what has clearly been described in a number of studies. And we in India have to be very, very pragmatic about what we are advising people or what we want for ourselves as well. This is the actual MCD screening test, right? And just look at this paper that came out late last year, right? Okay, so I'll just read that. MCD offers the potential for using a single test to screen multiple cancers, including cancers without guideline recommended screening test. All right, that's the first thing that it does. Currently, there is insufficient evidence to support it as a cancer screening tool that can reduce mortality. Remember, the aim is to reduce mortality. It poses several risks, several harms, right? Overdiagnosis, overtreatment, we know that. It has the potential lower patient adherence to recommended standard of care screening, because the patient is so fed up with the interpretation of this that he said, let it go. I don't even want to screen, with established strategies. The most effective strategy after getting a positive MCD remains unknown. Note the word unknown. Effect of MCD-based cancer screening on healthcare disparities, we don't know. The rich can get it, the poor can't get it. Do we know the impact of that? No. There is no clinical trial evidence to support MCD screening in clinical care, right? So this is the bottom line. And this is what I would like you to take home as a clear-cut message. Where does this put our homegrown test that Reliance is so aggressively marketing? It's called Cancer Spot. It's a multi-cancer early detection test. It was developed and validated on a retrospective cohort. And this was a study that was done and published last year. But what this study concluded, because nobody's going to read this and they're not going to hire, this study highlights the clinical utility of our approach, marking a significant milestone by demonstrating its effectiveness in an Indian population cohort for the first time. Right? So this is all it does. Our findings underscore the potential of such a product in enhancing early cancer detection and guiding clinical decision-making in diverse healthcare settings. So 2 keywords, right? It demonstrates effectiveness and it underscores the potential. Beyond this, does it do anything? No. Thank you very much.
Thank you, Rajesh.
Satish, I finished my talk. And
Thank you. Thank you, Rajesh. You can stop the screen sharing.
Yeah.
Rajiv bhai.
1 minute.
Yes.
Let him stop the screen sharing. I think you are still sharing your screen.
Yeah. Just 1 second.
Yeah, great. A wonderful talk, Raju. I mean, beyond our expectation. Usually, when you talk, the expectations are high, and today it was on a higher level in terms of you brought out the rationality of all this screening and genetic testing. So, wonderful presentation. I have one question. I mean, when we talk about the screening and genomic studies and all that, it always comes to our mind the incidence of Angelina Jolie. They say the Angelina Jolie effect. Some comments on that. Was she justified in doing mastectomy, bilateral mastectomy without disease?
So again, this is where shared decision making is very, very important, right? We now suppose a person comes to me and she says that, look, my mother had a breast cancer and now I've got this lump and I detect her also to have a breast cancer, right? She falls into a high risk group. So I will advise her to now do a BRCA test. And now actually our threshold for doing BRCA testing has reduced substantially than previous years, because the test is so easily available, it's not very expensive. And we will do that and we will find that, okay, she's BRCA positive, right? Something like Angelina Jolie. So now she's got an index cancer, we will treat her. But then she will say, what about my sisters? Because now I have to counsel for her sisters and her brother as well. People forget that male breast cancer, prostate cancers are also mediated by the BRCA gene. So now we screen all of them. And we find that one of her sisters has got BRCA1, BRCA2 positive. She doesn't have any symptoms. Mammography doesn't show anything. No lump. Now the question is that what do I do? So we say that, okay, the current recommendation as per what Angelina Jolie did was to remove both the breasts and to have a reconstruction. Huge psychological burden. And I have had patients who find it difficult to accept a contralateral mastectomy after being treated for one cancer in the breast and who is BRCA positive. I've had women like 2, 3, 4 years down the line and they say that, okay, now doctor, we are ready. Please do the salpingo-oophorectomy because of the ovarian cancer risk. Also do the contralateral mastectomy. But it takes 3-4 years before they are able to, process and accept that thing that they need a prophylactic surgery. So, there are many, many issues. But at the end of the day, I think it's an individual decision with the doctor. For some women, it can be very important. For others, it may be not so much, and they just want to get on back to their lives.
Same for variant of unknown significance.
Absolutely. I've had a lady, an architect, who her husband owned a big firm, and they worked there, and she was treated for breast cancer, and she fell into the criteria for testing. We tested her, and she came up with these three, four positive genes written in big letters, and then VUS. So it took, I think, at least about maybe 3, 4 counseling sessions with her and her husband before I said that we should just ignore this. They wanted me to act on it. This goes to show that in clinical practice, how difficult it becomes for us.
Kiran bhai, you had some question. Please go ahead.
Yes. Rajiv bhai, what I want to know is the liquid biopsy. What you told is only from blood or from any fluid of the blood or any fluid of the body?
See, liquid biopsy generally, it's a question of getting sufficient concentration. So it has been done on saliva. It can be done on body fluids as well. But essentially, you see, where is the role right now for liquid biopsy? Let me just give you an overview. For screening, we have seen that there is no role, right? But for monitoring post-treatment, for possibly early relapses, there is a defined place in certain cancers at certain point in time, right? Or where you find it difficult to access tumor tissue for a formal biopsy. And we can use the circulating tumor DNA assays as surrogate or sort of, proxy markers for active disease being present. And then, of course, you will do imaging and will try to determine where it is. And sometimes even imaging may be normal, but your assays may be showing such a high level that you will now know that this patient needs to come for follow-up at shorter intervals, and we have to do more vigilant surveillance. So this is currently the place of circulating DNA estimation. And I would think that in our practice, maybe in the whole year, we might not have more than single-digit patients who really are justified in doing a ctDNA test for subsequent follow-up. See, more important now is also the tissue base. It's not only the circulating. You actually need to do combined testing. It's what we call companion diagnostic testing or co-testing. And that is where it's very important, because the tumor tissue clearly gives us a more accurate representation. So where possible, you're going to biopsy it. But where not, and you have other issues, then you can do circulating tumor cells. I don't know really whether that answers your question, Kiran, but this is where the status is right now.
Specifically, what I want to know is that if there is a patient is having a pleural fluid only and nothing else is there in CT scan,
you should not do a ctDNA in an attempt to try to identify the cancer.
Okay.
You are better off doing an imaging. Patients who see, so I'll tell you what happens, where the problem happens for clinicians like yourself who are seeing patients first. Often we have the luxury of seeing a diagnosed cancer. You all have to actually detect that cancer. And one of the biggest masqueraders, as we know, is tuberculosis. And for people who are dealing with lung disease, that becomes a big issue, right? So now this patient comes along with a pleural effusion, and it's very unclear whether this is a cancer or it's a tuberculosis. You have tapped the fluid, and then you want a single test which can tell you whether this is a cancer or is not a cancer. Conventional cytology helps, but what is more important here is to first do the imaging before doing any say bronchoscopic studies for a central mass, right? I have seen any number of patients who have come after having undergone bronchoscopic guided FNACs and all of that for mediastinal nodes and hilar masses and all that, with the endoscopic ultrasound to guide the FNAC. But a simple imaging shows a large tumor. It shows some of the tumor at the periphery. Could easily have been done by a CT-guided biopsy, right? At the end of the day, I feel that bronchoscopy and a endoscopic ultrasound guide, the cost is going to be 4 times that of a guided CT scan biopsy. In the hands of a good interventional radiologist, the yield will be equivalent, if not better. So we maybe need to rethink our algorithm steps when we are presented with patients who have either a shadow on the chest X-ray or who have fluid in their in the pleural cavity. rethink that. Clearly the most important thing is the lesion identification. Very good imaging now we have. Tap the fluid first, send it for whatever markers you want to send, and then do a proper CECT. We've got into this habit of doing, screening CT scans, or what they call HRCT, because of a follower from the COVID era. See, in COVID it was a different matter. We were doing screening for COVID. You can't use that to screen for cancer. You've got to have a CECT. Right, a contrast enhancing. So just a few points that I wanted to make. I understand the difficulties that you face as clinicians in day-to-day practice, but I would suggest that you really need to think the steps of the algorithm and use the appropriate diagnostic.
Right.
Rajiv, you do use liquid biopsy for target therapy, I understand. And once you make the
like I said, Pinaki would be able to give you the exact, but if I think it's the number of patients in whom we have even attempted to do it.
Because if you have a tissue material with you where you have already made a diagnosis of, say, adenocarcinoma of lung, do you need a liquid biopsy, or you can?
No, of course not. No. Remember that the liquid biopsy is done only as a monitoring tool.
Okay.
Wherein you might not have imaging access to that particular anatomical area, or you are not able to get a biopsy for some reason. That it is so small that you can't, like you have an 8 millimeter nodule, right? You're not sure now, this is lung metastasis from the breast cancer, is it not? I mean, from the colorectal cancer or what, In that situation, you have an argument for doing a ctDNA and trying to do serial assays and, using that as a surrogate marker for getting tissue.
Okay. But if you have the tissue, it is the best.
If you have the tissue, it is always better, Now, they're also touting it as, why unnecessarily do an invasive biopsy when you can have this and all that. But the flip side of that is that the interpretation is not that easy. And it does require not only DNA, but RNA, and you've got to, proper exosome sequencing of it has to be done. So I think the use will expand in the years to come. But we are still, feeling our way. Companies are pushing it because they have the technology and they have AI, which helps the interpretation. Right?
Is it relatively new? Is it relatively new, or it was there?
It isn't. The circulating tumor cell as a possible tool came in, I think, at least about 8-9 years ago. But it's like I say, that only now are we beginning to see where it should fit into the algorithm for the management of the patient. So it takes time. I mean, don't expect that, we have a snap solution either to the diagnosis or the treatment of cancer. This is a complex disease, and these cells are smarter than our normal cells. Once they get into a sufficient volume and sufficient mutations, we should not take it that there is one thing that is a magic bullet that will be available tomorrow and we are all done with cancer. Not going to happen.
So how do you decide about target therapy? Which tests you do to,
So essentially, we do all these, we do what we call multi-gene panel, but it is directed and focused to that cancer.
Okay.
And then we determine, like for lung cancer. Now, if you, talk to the medical oncologist, Pinaki, Neeraj, or anybody, they will tell you that they will do the biopsy and they will do the ALK, they will do all of these tests, and then they will determine based on that. Biopsy will tell them whether it is non-small cell, small cell. Within non-small cell, is it adeno? Is it, so there are so many types of histological variants. And then within that, what is the molecular signature of the tumor? It's not enough just to have the full molecular signature. You must have agents that are able to counter that mutation, and agents that are FDA approved or clinically approved for use. So we now clearly have a huge number of these agents, but they are still not as enough as the number of mutations that you will identify. But yeah, we will do it in. So ultimately, see what happens here, that this is going to be a decision that's going to be individualized. We will never be able to make generalizations. It's the patient, the oncologist, and the technology, and the update and correct interpretation of the evidence in the literature, which is one of the most difficult things to do today.
What I understand, Rajiv, now from this talk and earlier talks which I have heard about this, that as more and more data we gather on genetic testing or genomic testing, all those unknown significance may become of significance later as we collect more data. Am I right?
It's possible. But on the flip side, you will have 80 to 90% which are reclassified as benign.
Right.
So your test has got to be much more discriminative, you know. You see, actually what should happen, I'll tell you, is that VUS reporting should decrease with improving tools and improving knowledge to the point that you have a higher proportion of likely pathogenic or pathogenic variants after the reclassification or the retesting. That's where we should be going, right? And that takes time. You know, I keep saying this again and again, that we have so much information that is available to us. So we have to clearly know what is information, what is knowledge, and where the wisdom lies.
So that requires 3 decades of experience in oncology.
I think it requires experience in oncology, but then, you know, the newer generations, the newer oncologists who are coming in are very aware of the information and the latest trials and all that. But the actual putting it into practice, that certainly is going to require some degree of mentoring. There's no question about that, you know.
So we have overshot a little bit, but very interesting, Rajiv. Thank you so much. It was really wonderful, and we'll have you again and again in future for some other topics. Thank you so much.
Thank you. Thank you for your attention.
Thank you all for joining. Thank you.